I learned no words that don't fit him. Yes.
What about you, Sylvia? Wait.
This is the... Thank you. I say, well, thank you for helping me to keep my head and not go too much. Everybody, thank you for not go too much to the hospital. But thank you for your kindness. You always very kindness from the bottom of my heart. Thank you. Thank you.
Oh, I need more than that. Quick. But you are the best. You have made my life so much easier. Thank you. Okay, we got a presentation to go. I know, I like that though.
It's so good to be back here, partly because the slides work. You know, it's always an iffy situation. So today, what I would like to do is review with you some aspects of COPD. I know you've had several lectures this year from very prestigious people, but I would like to kind of do a little review, focusing on how we can personalize the recommendations we have for COPD. Let me see if I can work the slides here. There we go. Okay, thank you. So I'm going to be focusing on this issue, the prognosis of the individual with COPD, or the other way of saying it, what can be done to improve individual outcomes. So I'd like to personalize this review. And it's going to be interactive and hopefully a little fun because it is a review. So I'm going to be asking some questions and handing out lotto tickets. Hopefully you'll win. I think Jackie gave you a little heads up on that. Okay, so let's start with the basics. A definition of COPD. It's a preventable and treatable disease with persistent airflow limitation that is usually progressive. It's due to chronic inflammatory responses in the airways and in the lungs to noxious particles or gases. And exacerbations of disease activity and comorbidities contribute to severity in a given individual. So you notice I highlighted certain words, and I'm going to try and focus on that today. Okay, but what I want to do first is ask my first question, which is, what are the types of COPD that we have? How do people present with different COPD presentations? Bronchitis. Give that woman a lotto. How about in the back? Emphysema is one. Okay, so Faye got a lotto. Okay, emphysema. And asthma. Give that man a lotto ticket. Okay, so here it is. Emphysema, chronic bronchitis, chronic asthma. But in order to have COPD, you don't only have to have the disease things of chronic cough or shortness of breath. You actually have to have enough severity in order to cause airflow obstruction. So in order to have COPD, you have to have an abnormal airflow. Okay, so how do we measure that? So the next question is, well, I'm going to skip to this slide here first. And that is, we have that chronic bronchitis, emphysema, and asthma. Notice that they overlap. So there are many patients who have both chronic bronchitis and emphysema. But look at that overlap with asthma. This is an area that's sort of a hot topic now in chest research and conferences. It's called the asthma COPD overlap syndrome. There are some individuals who have some components of COPD. They have hyperinflation, they have shortness of breath, they have fixed airflow obstruction, but then they also have other components. They have periodic wheezing, response to steroids. They have a history perhaps of asthma when they were younger. So this is the asthma overlap syndrome, and I'll be discussing why that's important a bit later, but the treatment is a little different for these individuals compared to emphysema or chronic bronchitis. So the next question, what is this test? Okay. A hand there. Right. She needs a lotto. And what the specific lung function test is a very simple test. It's called spirometry. Spirometry. Okay? And so you have a clip on your nose, you take in a deep breath, and then you blow out it as hard as you can, and the technician is there to make sure you keep on blowing out, blowing out, blowing out for at least 4 or 5 or 6 seconds. And then we measure the amount you breathe out in 1 second, and that's called the forced expiratory volume in 1 second, FEV1. Okay, so that is information you get from a plain spirometry, not a fancy pulmonary function test, not an exercise test, just the FEV1. But that number has been used for years to categorize COPD. So if you have someone who has mild airflow obstruction, they have an FEV1 greater than 80%. I hope you guys can see this from the back. 80% of predicted, meaning of people your gender, your age, your height, you will score above 80%. That's mild airflow obstruction. Moderate, 50 to 80%. Severe, 30 to 50%. Very severe, less than 30%. So these were called by a group called the Global Initiative for Obstructive Lung Disease, GOLD, as the stages of COPD. The implication being that as we age or the disease progresses, you move from GOLD 1 to GOLD 2, GOLD 3, then GOLD 4, based on the FEV1. So that's turned out to be incorrect. So we have a new GOLD classification. Why do we know that that's incorrect? And this is one of the big messages I want to give today. A few years ago, there were some studies on about 1,000 patients, followed for years. And they tracked their FEV1 to see if there was a decline in FEV1 over the years. So if you look at this, I don't know if you can read the bottom, it says mean annual decline in FEV1. And this is a histogram of frequency of how many patients had so much decline in FEV1. And I'm going to point out here, without a pointer, the 0 mark. So notice, that means that a fair number of individuals in this study had very little change in FEV1 over years. That's what I said. So if you plot the slopes of the decline of FEV1, you find that some people do decline in FEV1 over the years, and the bottom part of the graph shows it's a 10-year kind of slope. So some people have a significant decline, others have a non-significant slope. Doesn't change from the normal expected slope as we age. So what does this mean? Well, there's one researcher who made this statement, and I'm going to read it aloud for those of you who can't see it in the back. It has been our clinical experience that many patients with COPD receiving comprehensive management maintain stable lung function over long periods of time. And so everyone said, that fits our experience. So this was a statement that came out in 2011.
Casanova will say anything.
Casanova was what?
We'll say anything.
We'll say anything. Okay, so this slide here illustrates then the revised thinking of how we assess COPD. We look at FEV1, but we don't only look at FEV1 or the rate of decline. We actually look at two other measurements. One is shortness of breath. So in order for you to have a measured shortness of breath, there are some techniques, some questionnaires that you can use to actually grade the shortness of breath, and I'll show you a slide next that reveals that. Then also there's the number of exacerbations per year that an individual has. What is an exacerbation? Right, some change in your daily symptoms that's sudden, that requires you to change your medications, usually prednisone and antibiotics. So that's an exacerbation. It can be severe enough to lead to urgent care, emergency room visits, or even hospitalization. Hopefully not. But we pay attention to exacerbations. So exacerbations, if it's greater than 1 per year, is a risk factor that then puts you in a different stage of COPD. This is the Modified Medical Research Council scale for shortness of breath. And the middle category I'll read off for you is what I think they use to separate those with minimal symptoms versus those with significant symptoms. The middle category is grade 2. On level ground, I walk slower than people of the same age because of shortness of breath, breathlessness, or have to stop for breath when walking at my own pace. So that's grade 2. That puts you into a different category of symptomatology. Okay, so how do we put this all together? It's a little complicated here. I'm going to show it in 2 slides. One is this. They've produced 4 groups, 4 categories of COPD, A and B, and C and D. Those with mild to moderate airflow obstruction, and those with a low risk, less than 2 exacerbations per year, are categorized in groups A and B. And B differs from A in terms of whether or not they're symptomatic with shortness of breath. A doesn't have much in the way of symptoms, B does, shortness of breath. The same thing with groups C and D. D has shortness of breath, C doesn't. And the risk for exacerbation, 2 or more per year. And these people have airflow obstruction, 50 or less percent FEV1. So this is kind of a complicated slide. I like to look at this slide as a way of separating out these 4 categories because it gives me a message. And this is one of the messages that I want to give you today. So in the C and D category, where most of our individuals are, you have airflow obstruction with the FEV1 less than 50%, all the way to less than 30%. Or you have more than 1 exacerbation per year. If you're in D, you have symptoms of shortness of breath. C, you have few symptoms. And then you can go down to A and B. The B has more symptoms. A has less symptoms. They have less airflow obstruction. Why is this slide kind of important? I think that if you look at it, we've often been told you can't change your airflow obstruction. You can't change your FEV1. Although I did show you a histogram that showed that some people didn't have a decline, they actually had an improvement. But let's look at this slide again. Can you change the symptom of shortness of breath?
Yes.
Yes. Can you change the number of exacerbations you have per year?
Yes.
Right. So theoretically, you can push out of your box from D to C. Or even if you didn't have high amounts of airflow obstruction, you could go from D to B. But even within group D, you have people with different outcomes. You can have the same FEV1 for 2 different individuals and yet a different outcome. So if you control or prevent symptoms of shortness of breath and the number of exacerbations per year, you can at least push to the left side or the bottom of your box. So that's one of the messages that I think is important from this kind of analysis. So we're going to focus now for the rest of the talk on how do we control symptoms and how do we control exacerbations. And again, this is a personalized, individualized treatment because it has to adjust for the different person. So what's the best treatment that we know of for shortness of breath and COPD? Exercise, oxygen, what else? inhalers. What else? Lung transplant. Okay, so here's the answer. You're all a little bit correct except for the lung transplant. Pulmonary rehabilitation. There's lots of studies that show that if people undergo pulmonary rehabilitation, they actually improve their breathlessness better than medications. Definitely better than medications. You can improve the quality of life. You can increase exercise capacity, that we know, right? You can walk further, and you can do more, spend more time at the new step. But here's another thing that's been found by research. It actually decreases shortness of breath, and people who go through pulmonary rehab have less exacerbations. Look, we got two of the things that can move us in those boxes. Decreased shortness of breath, decreased frequency of exacerbation. So how long does this effect last?
As long as you're exercising.
As long as you keep doing all those things.
Exactamento. As long as you do all of those things. And I and Betsy and Jackie have the strong feeling that you need to maintain the activities of pulmonary rehabilitation. You can't just go out to your own gym and say, I'll do it. Well, you might be able to maintain that for a while, but if they track you, and they have done studies on this. For example, there was a study published this year, 88 Canadian patients. They checked these parameters after pulmonary rehabilitation, and then they checked it about 20 months later. Well, after 20 months, there was a drop in exercise capacity and an increase in shortness of breath. So the effect is not permanent, and you have to keep it up. And I think pulmonary rehabilitation is more than just exercise. It's monitoring. It's monitoring how your oxygenation is going, how are you using your oxygen equipment, how are you using your medications. Those things change with time because we have new medications. We have new ways, or not new ways, of delivering oxygen. Mental attitude does have something to do with it. And I'll be discussing that in a bit. So, maintenance. Okay, it's important to maintain the kind of activities you get in pulmonary rehabilitation. And in a sense, we're all here maintaining an activity of pulmonary rehabilitation. Okay, so when a person comes to me with COPD and says, Doc, I'm getting more short of breath, there's a checklist that I go through. The first thing is there a change in lung function? But then I have to make sure that it's not something simple. And so, just because I know most of you can't see it from the back, I'm going to go over this slide in piecemeal. The second thing, the second item here is we reviewed the inhalation technique. So how many of you have done that recently? Have you reviewed the inhalation technique using your medications at home? Dan has. Okay, so that's important. I'll be talking about that in a bit too. Then you have to check the adequacy of oxygen supplementation. It's surprising how many individuals kind of get used to a certain way of using their oxygen, despite perhaps having intermittent desaturation. They're using pulse oxygenation when they should use continuous, and they're not paying attention to periods like taking a shower or just walking around their house. They're trying to avoid having to use that oxygen. I'm going to go through a couple of slides talking about inhalation technique. As you know, there's pressurized aerosol, MDIs. Give me an example of that, guys. What's an aerosol liquid inhaler that you use?
Symbicort.
Okay, just about all of you are right except Spiriva. Although Spiriva comes in two forms. So, in a pressurized MDI with a mist aerosol, you have a slow, steady breath as you breathe in, then you hold your breath for 10 seconds, right? For the dry powder inhalers, and we're seeing more and more of them actually, you have to breathe hard and fast in. And then finally, for those who are not capable of coordinating, they actually use nebulizers with short-acting bronchodilators and one long-acting bronchodilator, one inhaled corticosteroid. So new avenues have come up for those who have different abilities to take the inhalation drugs. This is an instrument called the in-check dial. We haven't used it a lot, but Jackie, you've used it a few? Periodically. What this does is it measures your ability to generate a certain power or flow, because you need that in order to breathe in the dry powder. The dry powder, things such as Spiriva, hand inhaler.
Brio one of them?
Brio is a powder, yes. So you take this instrument and you just breathe in as fast as you can to see if it generates 60 liters per minute, which is the flow that's needed to create a cloud of the dry powder, and then breathe it in. And on the top of the dial, you just dial whatever particular agent or device you need to test the resistance for. So there's Advair on the top left-hand corner, and there's another dial that has Spiriva in it. The problem is that we're getting so many new drugs, it's hard to get a different dial for each new device. This is a guy who's using the in-check dial. There was a study done of about 200 people with severe COPD, trying to see if they could generate the 60 liters per minute flow for dry powder inhalers. And it turns out that about 20% of those 200 patients could not generate that flow. So they would have to be switched to either the nebulizer or an aerosol mist. The profile of those people who could not do it were usually, they were people who were kind of short and small, and they didn't have enough muscle strength to generate that liter flow. So this is not the type of guy we see who can't breathe in powders. Okay, so that's the inhalation technique. We've talked about trying to check on how your oxygenation is. Here are some of the other things we check for somebody coming in with shortness of breath. We check for heart disease. That's a comorbidity. That's what they call a comorbidity. It's often presents with people who are short of breath, and you think it might be lung disease, but it turns out it's either atrial fibrillation or a little bit of heart failure. So you need to check with your doctor to rule that out if you're having more shortness of breath. Anemia, very gradual, no obvious blood loss, but yet it can be there. You don't know it unless you check. Anxiety, depression. That's a cause of gradual shortness of breath because it impairs your ability to exercise and it impairs your ability to control panic. So you're breathing the wrong way, you're not controlling your breathing technique. What can we do, by the way, for anxiety, depression besides antidepressants and a trip to the psychologist or psychiatrist? Exercise, that's right. A supervised exercise program is very good to minimize anxiety, depression. Another new one is yoga. There's a proposal that yoga is worth a trial to try and diminish shortness of breath, because the meditation and the control of breathing does help with shortness of breath. There are other comorbidities that we have to check for every now and then. Lung cancer, with screening for lung cancer, we've talked about that before. Diabetes and osteoporosis. How can osteoporosis lead to more shortness of breath? It weakens your bones, makes them brittle, and if you have compression fractures of your back, it creates kyphosis, and your lung volume actually gets smaller.
Mine broke 3 times.
Oh boy. Okay, so that's the person who comes in with shortness of breath. We talked about how to deal with shortness of breath in terms of prevention, pulmonary rehabilitation. Now let's deal with the other part that moves you within the boxes, exacerbations. How are exacerbations harmful? Okay, that's a question I'll leave open. Exacerbations can lead to more exacerbations. What does that mean? That means that the person who is at most risk for having an exacerbation is someone who's already had one that year. So you have to be extremely careful if you've had one that you really have to prevent a second one. They can cause a decline in lung function. They can impair quality of life, shortness of breath, tiredness, anxiety, and depression. So here are some methods to prevent exacerbations. I would give a talk every year about the importance of the flu vaccine. It is the most important thing you can do right now, this time of the year. How many of you have had their flu vaccine? Everyone, I hope. Because it takes 2 to 3 weeks to work. There's a new high-dose flu zone that you guys know about, right? It's 4 times as strong in terms of the amount of viral particles, or pieces of the viral coat. So therefore, the antibody level that builds up in reaction is stronger and lasts longer. And there's actually been one study already that shows that using the senior dose of Fluzone decreases the amount of flu by 25%. Okay, so that's actually the experience. It's not just the antibody levels, but actually the incidence of flu. Can it cause a viral breakup? No, none of the flu vaccines actually can cause flu. And I tell people that it's the same as saying, if you take the peels of an orange and you put it into the ground, do you expect an orange tree? Because these are pieces of the viral coats. They've been fragmented. So you only have pieces. There are no living organisms in the usual flu vaccine that we give. There used to be a live attenuated virus vaccine, flu vaccine, that they used to give to people less than 50. It's still available, but less and less encouraged because the other stuff works just as well. But that's a good question because we meet that response in terms of refusal many times in the office. Okay, but it doesn't cause the flu. So you may have had a reaction, mild reaction. Usually the recommendation for the flu vaccine is you can still take it unless you've had an anaphylactic reaction. That means swelling of the tongue, face, breathing problems right away. Otherwise, at the most, it can cause a little bit of tiredness, a little bit of achiness the next day. It does not cause flu virus infections. Yes, Carl?
Are doctors routinely giving the stronger flu shot? And if you get the lower dose for lower effectiveness, can you go back and get the stronger one?
Okay, 2 good questions. One is, are clinics or doctors giving the high-dose flu vaccine? And if you had received the usual dose, should you go back and get the high dose? I don't think we're ready to do that last recommendation. I would say if you've already had the flu vaccine, that should be good enough for now, because I'm going to be talking about another thing you can do. I think that some clinics don't have the high-dose flu vaccine routinely. If you go to most of the pharmacies, though, it's really strange, but all of the pharmacies ask you the first thing, are you 65? And they give you the senior dose. So it's automatic, but some insurance programs have not geared up yet. Some hospitals have not geared up yet. Some clinics have not geared up yet. But I think this is the 2nd year that it's available, and I think by the 3rd or 4th year. Part of the problem is the FDA has not approved it yet to be superior to the regular dose, partly because we don't have enough experience. That's why that first paper was important, and we're going to have more papers after that. So I'm going to briefly skip over or just talk about the pneumococcal vaccine, just asking any questions. There's new guidelines about how often you give these vaccines. The PCV13 conjugate vaccine is the vaccine of choice to begin with at age 65. It's only given once. The PPSV23 is the old pneumonia vaccine. It covers more species of the pneumococcus, but these are not the more common species. The more common ones are found in the PCV13. So you still need to get the PPSV23 separated by a year. And if you've already received it, you could get 1 dose after 65, again, separated by a year from the PCV13. Okay? If no questions, I'll move to the next part. Smoking cessation, we already know that's one way to decrease exacerbations. There's a move to have repeat treatment with pulmonary rehabilitation after an exacerbation. And part of the reason for that is because hospitals are now being penalized by Medicare if they have readmissions for COPD exacerbations within 8 weeks. So guess what the hospitals are gearing up for? They're trying to all of a sudden do pulmonary rehab or comprehensive management programs so that when you get discharged from your exacerbation, they deal with you in clinics and in follow-up sooner with a lot more input. Dan?
A question regarding the pulmonary rehab. Most of the programs that are still remaining have long waiting lists. How can you get a 4-week PR class?
I know, that's a good question. What we've done at Providence is to try and structure a one-to-one kind of phase-in back to the routine program, especially if you've had pulmonary rehabilitation before. It's more of a reminder of, is your oxygenation okay? Is your use of medications okay? How are you feeling? What are your other comorbidities? So those questions are important because they do determine whether or not somebody gets sick again. Remember, an exacerbation leads to more exacerbations and maybe readmission, unless you pay attention to details.
What about reimbursement from insurance companies and Medicare for multiple rehabs?
Jackie, you can answer that better than I can.
36 visits in a lifetime.
Yeah.
This is why we discharge you kind of early. When you met your goals, we'll discharge you so that we don't waste your 36 visits. And it's a lifetime of 36 visits. Sometimes we get patients in that say 36 visits, and we don't. We see them, met their goals, and discharge them, put them in maintenance.
Doesn't
So
that
that
have
we
to
don't
change?
Yes, Dan, and we rely on people like you to help us out.
It should be unlimited if it was up.
Yes. So case management has been strongly recommended. What does that mean? That means somebody, either a nurse practitioner or a physician, sees you soon, sees you regularly, and goes through all these questions we've been going through today. What's a written rapid action plan? Anybody know that? We're going to get another lotto ticket for somebody who can tell me that.
Prophylactic antibiotics and prednisone.
Almost there.
It's a schedule of what to do when certain things happen, changes in your,
Correctamundi. You got it. So here's an example of what to do when you start feeling symptoms of an exacerbation. If you're getting more short of breath, you use pursed lip breathing to control the panic and the shortness of breath. That's number one. All of this is, by the way, written out so that you have something on your refrigerator to refer to in case you have problems. Then you increase the use of your short-acting meter-dose inhaler, like ProAir or albuterol, or you use your nebulizer for albuterol, short-acting bronchodilators to help you through this episode. Then you get, through a call to your doctor or you already have it prescribed, antibiotics for treatment of probable bacterial infection. And during the flu season, it's important, if you have fever, muscle aches, and a dry cough, to get the antiviral Tamiflu. Now, there are a couple of other antivirals, but they're inhaled medications or IV medication. It's really Tamiflu. There was a study done, just published this year, 5 centers throughout the country, thousands of patients. They found that most seniors over 65 who called in for their Tamiflu or called in with their symptoms of flu called after 48 hours, 70%. And Tamiflu is most effective if you call within the first 24 or 48 hours. So remember that. There's got to be a rapid action plan if you have anything that looks like, sounds like, smells like the flu. Okay? If you have shortness of breath as well, you may need a course of corticosteroids. That should be part of your action plan. And then, if necessary, better early than late, you go to the emergency room or urgent care. Any questions on the rapid action plan? Okay, this is an alphabet soup. Yes, question?
You've had a flu shot and you're starting to have symptoms of flu. Did you take that action?
So if you have flu symptoms after the flu shot, it's not the flu.
No, I'm not saying right
Okay.
after, like over time.
Over time, yeah. The flu vaccines are only partially protective. It's still better, by the way, than the other vaccines we have, like pneumococcal vaccines. But if you develop flu symptoms after a week or more, you should call and get the Tamiflu. The CDC now reports, and you can look at a map on it if you just look at the site, the activity in California and most of the country is sporadic right now. There are a few unlucky states like Oregon and Iowa and Puerto Rico that have more flu going on now, but I think it's beginning this year already. You know, we usually have 3 viruses that are, or virus pieces that are in the vaccine. The H1N1, this year is the California 2009. The Switzerland, which is H3N2, influenza A virus particles. And then finally there's a B virus particles. But the answer to your question is yes, you still treat yourself with Tamiflu. Okay, so this is an alphabet soup. Oh, Dan?
Regarding the rapid action plan,
Yes.
what should we look for in our sputum as far as determining whether we should start antibiotics?
Okay, that's a good question. It is often stated that if you don't produce a sputum, you just get shortness of breath and a cough, you don't use the antibacterials. But some of my patients with emphysema, for example, or chronic airflow obstruction, have difficulty coughing it up. So I cover them for antibiotics with antibacterial antibiotics, even if they don't bring up any sputum. If they have something that sounds like a bronchitis, like increased cough, and maybe a little bit of sputum, not necessarily purulent, fever, achiness, yes, I would give them the antibiotic. But most of the rapid action plan suggestions have been if you cough up purulent yellow or green sputum, then you get the antibiotics. But I don't think that always works. And so we have the risk of over-treating, but I think for our individuals with severe airflow obstruction, you want to be aggressive. So here's the alphabet soup of different short-acting and long-acting bronchodilators and steroids that you can use. And so I'm illustrating this slide not because I want to advertise the different kinds of things you can do, but I want to illustrate a couple of points here. Because remember that overlapping slide that we showed you of bronchitis, emphysema, and asthma? If you have something that's part asthma or chronic asthma, you want to really concentrate on getting those inhaled corticosteroids in. There's several brands, but they all work similarly. If you have chronic bronchitis and emphysema without asthma, then you focus on a long-acting beta agonist, that's LABA, or a long-acting muscarinic antagonist, that's LAMA. 2 kinds of bronchodilators. They work by different mechanisms. They can actually be used together, the dual LABA and LAMA. 3 examples of that are new: Anora elliptica, Stiolto, very brand new, and there's one called UT-Bro or something like that, just came out last month. They're kind of expensive, and so you really have to kind of look at these drugs because of that expense before you jump on that bandwagon. But there's a question now that's come up that a lot of our patients who are on dual long-acting beta agonists and steroids may be at risk for having some increased incidence of pneumonia. Has anybody heard of that before? Okay, so the steroid use in individuals with emphysema and chronic bronchitis is sometimes associated with a slight increase in pneumonia. So some investigators have said, well, if I have somebody with pneumonia, I'm going to take them off their Advair or their Brio or their Symbicort or their Dulera and put them on either the dual LABA-LAMA or the isolated single agent LABA or LAMA. What's an example of a LAMA? Okay, Ceravent, Formoterol. What's a good example of a LAMA? Spiriva. Okay, so those are used often in treating people with emphysema or chronic bronchitis. So again, there's a little concern about the use of steroids with people who have COPD, but it's not. It used to be recommended that anybody with 2 or more exacerbations a year should have the inhaled steroids too. That's why Advair, Symbicort, Dulera are used quite often. Okay, but we're kind of moving away a little bit from that. Finally, in people who you have frequent exacerbations over the year, like 2 or more, and they have chronic bronchitis, there are some other agents, roflumilast, theophylline, and N-acetylcysteine, but only for those people with chronic bronchitis. For emphysema patients, I think you've all heard of a study that went on, I think Harvard participated in that, where they had daily macrolides, azithromycin. So it did decrease by a significant amount the number of exacerbations of people with emphysema COPD. But there's still a reluctance to use it in a widespread manner because it has potential side effects. Hearing has to be checked. People with heart disease, you can have an increased QT, EKG abnormality. And then what I worry about most with my patients who have other infections, you can get a resistance to azithromycin, which is actually one of our mainstays when we treat people with MAC. That's another topic for conversation. But we have to be worried about giving people azithromycin long term because of these potential consequences. Yo, yes.
Takes budesonide and performance in a nebulizer. Which LABA or LAMA is it?
Budesonide is an inhaled corticosteroid. So it is useful for people who cannot master the coordination of using an inhaled actuation with powder. So I think it's a good drug, but then you've got to remember, if you don't have an asthma type picture, you have to worry about the risk of pneumonia, so you have to monitor those people fairly frequently. Okay, so this is my major point that I wanted to discuss today. Hoping that I touched bases on these points. What can be done to improve individual outcomes? And so what we've done is I want you to take home 2 messages. One is the progression of COPD is a mixed bag. Some people are stable, some people are not. No matter which group you're in. You could be in group D. Some people will be stable, some people will worsen. Okay, how can you manage then to improve your own prognosis as an individual? You have to go through battling shortness of breath and other symptoms in a supervised manner. Make sure you identify comorbidities such as heart disease, diabetes, anemia, anxiety or depression. And then you have to prevent and treat exacerbations. So I'm going to stop there because I think along with this, you can have some fun. Thank you. I'm open to questions. Okay, Carlin?
I was surprised to see theophylline back on your list, because I had been on it years before, and probably have been off of it for 15 years.
Yes.
Is it coming back?
No, only for chronic bronchitis. And the problem is that it's difficult to manage because it has a low threshold for adverse effects. You can get side effects quite often. So we're not using theophylline. It's only when you're desperate, the person's having repeat exacerbations, wheezing and coughing multiple times a year, that you think of adding that to it. Or the other drug, roflumilast. Okay, Dan?
Is sleep apnea a comorbidity of COPD?
It can be if you have the right body habitus and space in the back of your throat. If you have a decreased space in the back of your throat, you will be at risk for having sleep apnea. And so that's a standard medical question when somebody comes in. If you're having shortness of breath or if you have cardiac arrhythmias, hypertension, you're asking, do you snore? Do you fall asleep during the day? And if those questions are positive, you test for sleep desaturation or for obstructive sleep apnea. Did I answer your question? Mm-hmm. Okay. Yes, Cass.
I just want to say, Dr. Chang, I'm very proud to know that you're one of the best doctors that I've ever worked with clients. You have so much heart for your clients, and I'm so proud of you.
Thank you, Cass.
You
Thank
make
you.
me to know that one day, if I have to go back to Africa, I will have so much joy to do the work of elderly people.
Thank you. I know those are heartfelt comments. Thank you. I want to introduce Carmela, who's from our office. And if anyone is interested, she is a research coordinator for UCLA Peninsula Pulmonary. And we have one project that's out there that she wants to tell you about. And that is the use of a triple drug, LAMA, LABA, inhaled corticosteroid, for people who have COPD. And it's going to be some of the newer drugs, Anora elliptica, plus this new director testing, plus Brio elliptica. So sort of fresh off the drugs that are coming out now for treatment of COPD. Yes, question?
What's the difference between COPD and congestive heart failure with pulmonary hypertension?
Okay. The question was, what is the difference between COPD and congestive heart failure as contributing to pulmonary hypertension? They both can contribute to pulmonary hypertension. CHF, especially if it's a diastolic kind of thing where your muscles are stiff, can cause pulmonary hypertension. COPD, when in its severe stages with low oxygen, can cause pulmonary hypertension. One is treatable. Well, actually, they're both treatable. But you have to understand what the component of each is. And so you have to maximize your treatment for congestive heart failure and also maximize your oxygenation and treatment for COPD.
Because I have congestive heart failure with pulmonary hypertension. So that's why I was asking what's the difference between that and COPD.
Yeah. Now there is a pulmonary hypertension that's even without congestive heart failure, and that's a different story. You have both? Okay. So then you might need more invasive studies and more elaborate treatment.
It's secondary to my sickle cell disease.
Okay, excuse me for a second. Let me just finish up.
It's secondary to my sickle cell disease.
I see. Yes.
That's how I'm
Yes.
secondary to that. That's why I was asking what's the difference.
Right. Right. So that's a challenge because you have more than one mechanism for causing that. So the question here was atrial fibrillation. Is that a comorbidity? Yes. Actually, fairly commonly. Because as you age, the wires, so to speak, your conduction pathways in your heart age too, and sometimes they get interrupted and then you get this fibrillation, which then produces like a 5% chance per year of a stroke unless you get anticoagulation. And it can induce congestive heart failure. It can drop your cardiac output. Yeah. Okay. Any other questions? I got one back there.
Several of us have developed a cough lately, it seems like, that doesn't want to go away. How long should that linger? How long should we be worried about that?
Okay. So the question is, we have a cough that's been lingering. What should we do? Is it the same thing for everyone who is developing a cough at this time of the year? Cough is actually probably the most common symptom that we see in a pulmonologist's office, and it has multiple possibilities as the cause. One is, very common, is a sinusitis or an irritation of the upper airways after a cold. And that can produce a prolonged cough over weeks. Now that can be due to any kind of respiratory virus. Usually it's a respiratory virus because you get it from other people. So in that sense, yes, groups of people can have a similar cough. But it's usually a plain old respiratory virus, like a cold virus. And with time and attention to details about the complications of upper airway syndrome sinusitis, you can get it better. You should be able to get it better. It's not doesn't mean that there's a new kind of bug, like a flu-like virus, around. Then there are other causes commonly for causing a chronic cough, but that's another lecture as well. But the most common thing at this time of the year is a virus leading to an upper airway syndrome. But you can also get a bronchitis, for example. If you're asthmatic or COPD, you can react to that and have a prolonged cough too. Questions here?
Could you enlarge on prednisone for me? Prednisone.
Prednisone, would I expand on it a little bit?
Yes, every doctor I go to says prednisone, except one in your office.
Okay. Okay, so if you have chronic asthma, sometimes you can't get around without prednisone, at least a low dose. You have to use the inhaled steroid as well. And sometimes you get referred for Xolair, which is an antibody against the allergic antibodies of asthma. If you have COPD that's due to emphysema or bronchitis, you should get the prednisone mainly for exacerbations. And it should be, with the newest information, a short course, not something that lasts for months. So if you're using prednisone over weeks to months and you have COPD not due to asthma, I think we have to re-examine that. Okay, there was one other question on that side of the audience. No? Okay. Yes? Okay, what is the difference between chronic bronchitis and bronchiectasis? So chronic bronchitis was part of the spectrum of COPD. Bronchiectasis, usually there are multiple possible causes of bronchiectasis, and it really is scarring of the bronchial tubes. It's different from chronic bronchitis. They both can cause chronic cough. Usually the organisms associated with the bronchiectasis are much more exotic and difficult to treat. So for example, there's Pseudomonas, there's staph, there's the Mycobacterium avium, and other things, especially if you're on antibiotics for a long time, you can develop. So the problem with bronchiectasis is that you can get different kinds of organisms that are difficult to treat, and you have to pay attention to drainage. You have to pay attention to getting rid of the accumulations of mucus in your scarred up bronchial tubes, because if you don't, the bugs love to go into a culture type atmosphere there and they become more resistant because the antibiotics don't get delivered right in the middle of the mucus. So you need to pay attention to clearance, airway clearance with bronchiectasis. Okay, I hope I answered that question a little bit. Yes? Terry.
If you have shortness of breath and you're on oxygen, is raising the oxygen level a good idea or not a good idea?
Okay. Very good question. The question was, if you're short of breath and you're on oxygen, do you just raise the oxygen? Is that a good idea or a bad idea?
Bad idea.
So, it depends. If your oxygen, as measured by an oxygen oximeter, is low, that is below 90 consistently, you need to raise it. Or you have to raise it when times when it does drop below 90, which is usually during exertion. Okay? If you have some saturations that are like 95 or higher, then you shouldn't raise your oxygen, because if you have severe enough lung disease, you will also have chronic carbon dioxide retention, not getting rid of the waste gas. And when you give too much oxygen to those individuals, you turn off these little nerve receptors in your carotid artery, near your carotid arteries, called carotid bodies. And then you don't breathe as much. So guess what happens to your carbon dioxide? It goes up. So in those individuals, you don't want to increase their oxygen above 92 or 94%. You want to keep it to a minimum that's adequate. Did I answer your question? Good. One more question.
What do you do for that cough due to sinus drip?
So what do you do for that prolonged cough with a postnasal drip? Right?
Yes.
ENT. You have to see an ear, nose, throat specialist, because they have to look up there, they have to culture if there's any infection. And they have to use, if it's not infected, they have to use some measures to try and keep things clean. So they can use sinus rinse kind of lavages with saline or distilled water. Okay? Yeah, you're welcome. So I'm going to end here and say Happy Thanksgiving, guys. Thank you.
One that doesn't like nuts and chews. Part of it's I paid too much for mine.
Okay.
This is a ceramic bowl that Joseph made at his pottery class. And periodically he donates
Tenor. Take it home and think of Joseph. Every time you look at it, dust it or wash it. Art, did we get a head count from today? It was pretty high up there, wasn't it? 81? Wonderful. Wonderful. We'll break fire codes next month. The wine.